All right, we're picking up in Chapter 8, page 271, Patient Assessment. After you have determined that a pulse is present, next, determine its adequacy. This is done by assessing the pulse rate, pulse quality, and pulse rhythm. Pulse rate. For an adult, the normal resting pulse rate should be between 60 and 100 beats per minute, and could be as much as 100 beats per minute in geriatric patients. In pediatric patients, generally the younger the patient, the faster the pulse rate. In well-conditioned athletes or in people taking heart medications such as beta blockers, the pulse rate may be considerably lower. Look at Table 8.5. Table 8.5 shows the normal ranges of pulse rates for adults and children. To obtain the pulse rate in most patients, you should count the number of pulses felt in a 30-second period and then multiply by 2. A pulse that is weak and difficult to palpate, irregular, or extremely slow should be palpated and counted for a full minute. A pulse rate is counted as beats per minute. We're now on page 272. However, in reporting the pulse rate, it is not necessary to state or write beats per minute after the number. In assessing the pulse rate in an adult patient, a rate that is greater than 100 beats per minute is described as tachycardia, and a rate of less than 60 beats per minute is described as bradycardia. Tachycardia and bradycardia. Pulse quality. You should always report the pulse's quality whenever reporting or recording the pulse. The pulse is generally palpated at the radial or carotid arteries in adults and at the brachial artery in infants, because it is normally strong and easily palpable at these locations. Therefore, if the pulse feels of normal strength, you should describe it as being strong. You should describe a stronger than normal pulse as bounding, and a pulse that is weak and difficult to feel as weak or thready. With a little experience, you will be able to easily make the necessary distinctions. Pulse rhythm. When you are assessing the pulse, you must also determine whether the rhythm is regular or irregular. When the interval between each ventricular contraction of the heart is short, the pulse is rapid. When the interval is longer, the pulse is slower. Regardless of the rate, the interval between each contraction should be the same, and the pulse should occur at a constant, regular rhythm. The rhythm is considered irregular if a heart periodically has a premature or late beat, or if a pulse beat is missed. Some people have a chronically irregular pulse. However, if an irregular pulse is found in a patient with signs and symptoms that suggest a cardiovascular problem, the patient likely needs advanced cardiac assessment and life support. Therefore, depending on your protocols, you should call for ALS backup, arrange for an intercept by paramedics, or initiate prompt transport to definitive care. With practice, you will be able to assess whether the pulse is too slow, too fast, or irregular without actually counting the pulsations. This will help to speed up your assessment of the ABCs and allow you to focus on finding other potentially life-threatening problems. A pulse rate that is too slow or too fast may change decisions related to transporting your patient. The pulse should be easily felt at the radial or carotid artery and have a regular rhythm. If it is difficult to feel or irregular, the patient may have problems with his or her circulatory system that may need further evaluation later in your assessment. The skin. The skin has many functions. It helps maintain the water content of the body, acts as insulation and protection from infection, and has a role in regulating body temperature by changing the amount of blood circulating through the surface of skin. Assessing the skin is one of the most important and most readily accessible ways of evaluating circulation and perfusion, blood oxygen level, and body temperature. A normally functioning circulatory system perfuses the skin with oxygenated blood. A lack of perfusion or hypoperfusion will result in hypoxia of the brain, lungs, heart, and kidneys. In most situations, hypoperfusion is caused by shock. The degree of hypoperfusion and how long it lasts will determine if a patient will sustain permanent damage related to the hypoxia. Perfusion is assessed by evaluating a patient's skin color, temperature, moisture, and capillary refill. Skin color. Assessing the skin helps you to determine the adequacy of perfusion. Adequate perfusion meets the current needs of the cells. Inadequate perfusion causes cells and tissues to die. Many blood vessels lie near the surface of the skin. The skin's color is determined by the blood circulating through these vessels and the amount and type of pigment that is present in the skin. Blood is red when it is actually saturated with oxygen. Blood is red when it is adequately saturated with oxygen. As a result, skin in most people will not hide changes. Let me back up. As a result, skin in lightly pigmented people is pinkish. The pigmentation in most people will not hide changes in the skin's underlying color, regardless of the person's race. In patients with deeply pigmented skin, changes in color may be apparent only in certain areas, such as the fingernail beds, the mucous membranes in the mouth, the lips, the underside of the arm and palm, which are usually less pigmented, and the conjunctiva of the eyes. The conjunctiva is the delicate membrane lining the eyelids, and it covers the exposed surface of the eye. In addition, the palms of the hands and soles of the feet should be assessed in infants and children. Poor peripheral circulation will cause the skin to appear pale, white, ashen, or gray, possibly with a waxy, translucent appearance like a white candle. Abnormally cold or frozen skin may also appear this way. When the blood is not properly saturated with oxygen, it appears bluish. Therefore, in a patient with insufficient air exchange and low levels of oxygen in the blood and vessels become bluish, and the lips, mucous membranes, nail beds, and skin over the blood vessels appear blue or gray. This condition is called cyanosis. See figure 8.16. High blood pressure may cause the skin to be abnormally flushed with red. In some patients with extremely high blood pressure, all of the visible blood vessels will be so full that the skin will appear to be a dark reddish purple. A patient with carbon monoxide poisoning or a significant fever, heat stroke, sunburn, mild thermal burns, or other conditions in which the body is unable to properly dissipate heat will also appear to have red skin. Changes in skin color may also result from chronic illness. Liver disease or dysfunction may cause jaundice, resulting in the patient's skin and sclera turning yellow. The sclera is the normally white portion of the eye and may show color changes even before skin color change is visible. Skin temperature. Normal skin temperature will be warm to the touch. Your normal body temperature is 98.6 degrees Fahrenheit. 98.6 degrees Fahrenheit. Abnormal skin temperatures are hot, cool, cold, and clammy. Clammy is considered cool and moist. When the patient has a significant fever, sunburn, or hyperthermia, the skin feels hot to the touch. The skin will feel cool when the patient is in early shock, has mild hypothermia, or has inadequate perfusion. With poor perfusion, the body pulls blood away from the surface of the skin and diverts it to the core of the body. The result is cool, pale, clammy skin. In your primary assessment, this is a good indication of hypoperfusion and inadequacy of circulatory system function, or shock. The skin will feel cold when the patient is in profound shock, has hypothermia, or has frostbite. Body temperature is normally measured with a thermometer in the hospital. However, in the field, feeling the patient's forehead with the back of your hand is usually adequate to determine whether the patient's temperature is elevated or decreased. Skin moisture. Dry skin is normal. Skin that is wet, moist, often called diaphoretic, or excessively dry and hot suggests a problem. In the early stages of shock, the skin will become slightly moist. Skin that is only slightly moist but not covered excessively with sweat is described as clammy, damp, or moist. When the skin is bathed in sweat, such as after strenuous exercise, or when the patient is in shock, the skin is described as wet or diaphoretic. Because the skin's color, temperature, and moisture are often related signs, you should consider them together. When recording or reporting your assessment of the skin, you should first describe the color, then the temperature, and last, whether the skin is dry or moist. For example, you could say or write, skin, pale, cool, and clammy. Again, these characteristics are important findings in the primary assessment because hypoperfusion can lead to serious consequences if treatment is delayed or ignored. Capillary refill. Capillary refill is evaluated to assess the ability of the circulatory system to restore blood to the capillary system. When evaluated in an uninjured limb, capillary refill time, or CRT, may provide an indication of the patient's level of perfusion. It should be kept in mind, however, that capillary refill can be affected by the patient's body temperature, position, pre-existing medical conditions, and medications. Remember that other conditions not related to the body's circulation may also slow capillary refill. These conditions include, but are not limited to, the patient's age, exposure to a cold environment, hypothermia, frozen tissue, or frostbite, and vasoconstriction, narrowing of the blood vessels, such as with hypoperfusion or cold extremities. Injuries to bones and muscles of the extremities may cause local circulatory compromise resulting in hypoperfusion of an extremity rather than hypoperfusion of the body in general. To test capillary refill, place your thumb on the patient's fingernail with your fingers on the underside of the patient's finger and gently compress. Figure 817A. That would be on the next page. Flip there and look at it. Figure 817A. Flip back to page 273. We'll pick up in the last paragraph there. The blood will be forced from the capillaries in the nail bed. Remove the pressure applied against the tip of the patient's finger. The nail bed will remain blanched and white for a brief period, as the underlying capillaries refill with blood. The nail bed will be restored to its normal pink color. Capillary refill should be prompt, and the nail bed color should be pink with adequate perfusion. The color in the nail bed should be restored to its normal pink color within 2 seconds, or about the time it takes to say capillary refill, at a normal rate of speech. I'm going to stop now on page 274, and we'll pick up there in the next video.